Welcome everyone. Thank you for joining us today for our first presentation during Telehealth Awareness Week. My name is Becky Sanders and I'm the Program Director for the Upper Midwest Telehealth Resource Center. Before I turn everything over to our presenters today, I just wanted to go through some housekeeping. Normally our virtual office hours do only last about 30 minutes. We do expect going over today because there's just so much information to cover. So we'll leave some time at the end for question and answer. We will also be requesting that you complete a very short survey at the end because we are federally funded and our funders always like to hear what we're doing and feedback for our programs. So today we're in a meeting format, which means all of you do have the opportunity to unmute yourselves to speak and ask questions. We do, however, ask that you either put those questions in the chat box or hold them until the end of today's presentation. And we will be recording this. We'll post it on our YouTube page as well as our archived webinars page on our umtrc.org website. The slides will also be posted on the website in a PDF version. All right, so without further ado, I do want to introduce you guys to Taylor Kenyon and Amna Anwar, and they are a couple of my colleagues, or our colleagues with Carolyn here at the Indiana Rural Health Association. And as you know, the Upper Midwest Telehealth Resource Center covers the 4 states of Illinois, Indiana, Michigan, and Ohio, and we are a department underneath the umbrella of the Rural Health Association. So Taylor and Amna, take it away.
Thank you so much, Becky, and welcome everyone to our presentation. If you guys are not already tired of hearing about coronavirus, we have some more information about COVID and the Delta variant. Our presentation will be a brief review of the current evidence that is on Delta variant of the coronavirus. Next. So as Becky mentioned, I'm Amna Anwar. I'm a Senior Director at Indiana Rural Health Association and the epidemiologist at the Indiana Rural Health Association. I also oversee some of the programs that are pertaining to substance use disorder within the Indiana Rural Health Association. I am joined by my colleague, Taylor Kenyon, who is the Project Director for the tobacco-related programs that are at Indiana Rural Health Association. And our contact information is on these slides when you will receive them if you have any questions after our presentation. So the purpose of this presentation is basically to review the recent advances in our understanding of the COVID-19 Delta variant and its implication to the mitigation efforts. And we will also provide you with some of the resources and the toolkits that are available at the governmental and the non-governmental sites for the information that is provided and how to mitigate the Delta variant in the current times. Next. So for our presentation, the roadmap that we will follow is that I will give you a brief information about the information source review, most of the information resources that we have utilized for these presentations, and then give you an information about the variants of concerns classification, how the different variants are identified during this pandemic, and what is different in different variants. We will delve a little bit more detail into a little bit more detail about the COVID-19 variant primer, its symptomatology, the diagnosis, and the epidemiology when it comes to the COVID-19 Delta variant will be the one that we will be discussing. And then I will also provide an overview of the standard of care when it comes to the COVID-19 infections. Then my colleague will take up on the mitigation techniques that are available or that are recommended for the COVID-19 and Delta variant specifically, and then the vaccine adoption and distribution as it relates to the outbreak dynamics in the United States. And then he will also provide you a little bit more information about yet other COVID-19 variants which are out there that may prove to be the future threats when it comes to this pandemic. So starting with the resources, as I mentioned, we have relied heavily on the governmental agencies like CDC for the MMWR reviews that they put out weekly. We have also relied heavily on the information that is provided over here from the FDA and the HHS and the state departments of health. Certain other international or some non-governmental agencies that from where the information has been curated for these presentations include the World Health Organization, or as my colleague likes to call it, WHO. I have always called it WHO, and then the National Association of County and City Health Officials. We will also provide some information without endorsing any vendors, such as Abbott, and the systemic reviews and meta-analysis from resources such as Cochrane. Now, the variants of concern primer. I will mention what the variants of concerns are and how how have we come to know about these variants of concerns. If you can move on to the next slide. This information, probably you already are aware of it, but I will just go over it just to provide the premise of the discussion that will follow this, is that this is not the first time that the human race has been faced with coronaviruses. Coronaviruses have been out there, and it is a large family of viruses that can infect humans as well as other animals such as camels, cattle, cats, and bats. Why do we call them coronavirus? It is because the shape of the virus resembles that of a crown, and it is due to the spike proteins that are present on the outside of that virus that protrude out. I mean, that is a visual that we have become so used to seeing on TVs and on the print material as well. But as you can see on this image, this is the image taken from an electron microscope inside a human body in the lungs, where these spike proteins are just seen as small projections which are protruding out of the virus body. Next. As again, it is a repetition. The coronavirus was first identified in December of 2019 in the Wuhan, China. It is very contagious and has quickly spread around the world. Now, when it came to naming the virus, the International Committee on Taxonomy of Viruses is the one that came up with the name, that is the Severe Acute Respiratory Syndrome coronavirus. But this time around, it is the coronavirus 2, because this same name, the SARS-CoV, was given to a virus that caused the epidemics that were in 2002 and 2004. But this is the SARS-CoV-2 as the new, and this name was given in February of 2020. Now, for the layman or the common use of this, SARS-CoV-2 is not the name that we are familiar with. It is COVID-19, which was given to this virus or this disease by WHO in the same month in 2020. And in this name, the CO stands for corona, I obviously for virus, and D for disease. And 19 is the name given to this virus because it was identified in 2019. Next. Now, when we're talking about viruses, I think all of us are very familiar with the flu virus. There are various different variants at a given time in a year that are out there circulating in the environment that are infecting people, causing flu. So what is different in viruses is that whenever a virus jumps from one person to another, it mutates. Some of these mutations, they go unnoticed, and it's kind of like the survival of the fittest. The mutations which make the virus more transmissible, which make it more deadly, and which make its ability to infect and overcome its host cells, usually are the ones which give rise to those variants which remain in circulation and which eventually become the variants of concerns. Now, during the late 2020, the emergence of the variants that posed increased threat in the global public health, they prompted the characterization of the COVID variants as variants of interest and then the variants of concern. Now, when we are talking about these various different variants, there is actually a specific system to name these variants, and those are based off of the genetic lineages of these variants of the COVID-19 viruses, and the authorities to name these viruses depends upon the GI-SID, next strain, and PANGO, which both the WHO or WHO and CDC endorse, and they utilize those nomenclature for the variants. But for layman like you and I, all those names are pretty complex and they can get confusing. So WHO actually recommended the use of the Greek alphabets to name the various different variants as we know now. So there is alpha, beta, gamma, delta, and then the list goes on when it comes to the various different variants of interest and variants of concerns for COVID-19 virus. Next. So what is a variant of interest and how does it become a variant of concern? Now, for any variant for the COVID-19 virus, which has a genetic changes that are predicted or known to affect the virus's characteristics such as transmissibility, disease severity, immune escape, diagnostic or therapeutic escape, and identified to cause significant community transmission are multiple COVID-19 clusters in multiple countries with increasing relative prevalence alongside increasing number of cases over time or other apparent epidemiological impacts to suggest an emerging risk to global public health. I read through the slide because this is the exact definition that is available on the WHO website for the variant of interest. So for any variant of the COVID-19 virus for it to be considered a variant of interest, it has to have both of these conditions met. Otherwise, it is not considered as a variant of interest. Next. So SARS-CoV, but what is the variant of concern? So once we have identified a variant of interest, for it to become a variant of concern, it needs to have one of these, one or more of these conditions. It needs to have increase in transmissibility or detrimental change in COVID-19 epidemiology, increase in virulence or change in the clinical disease presentation, or decrease in effectiveness of public health and social measures or available diagnostics, vaccines, or therapeutics. So once we have a variant of interest, satisfying the definition that was given in the previous slide, and then that variant of interest has one or more of these three conditions met, then it is considered as a variant of concern. Right now we have 4 variants of concerns, as you can see. The first one that was identified in late December of 2020 in United Kingdom as the Alpha variant. Then around the same time, a Beta variant was identified in South Africa. And then in January, we identified Gamma variant. The origin of that variant was the country Brazil. But the one that we are going to be talking a lot about right now is the Delta variant, which was actually identified in India in October of 2020, but it became the variant of concern in May of this year, that is 2021. Now, how are these different variants different from each other? Now, I tried to create this table, tried to keep some of the basic things as if you look back at the conditions that satisfy the requirements for a variant to become the variants of concern, and just provide you a side-by-side analysis of all of these variants. Now, in Alpha and Beta, when we are talking about the spread, there was an almost 50% increase in the transmission of this virus. Gamma was faster than the other variants, but Delta is considered to be the fastest in all of these 4 variants of concern when it comes to the spread of the disease. Now, severeness of illness and death in both in Alpha only, there was a slight increase in the risk of the severe illness and death. While in Beta and Gamma, there was no increase in the severeness of illness per se by the virus itself. Whereas in Delta, again, there is no increase in the severeness of the disease or the death by any of the mutations that are present within the variant. But because of its very high transmissibility or very high spread, it is infecting more people and it is causing increased death and severe illness in that manner. But like in itself, the virus itself is not causing the more severe disease or deaths. Now, vaccine effectiveness is, I think, the hot topic right now when it comes to the various different variants that are out there. Now, the vaccines were found to be effective, and I say like in a blanket statement, in all the 4 variants, the vaccine are vaccines are effective in against the severe disease, hospitalization, and death. So all of the variants of the COVID-19, variants of concern of COVID-19, which are out there, the vaccines that we have, the 3 different vaccines that we have from Moderna, from Pfizer, and Johnson & Johnson, all of these 3 are effective in reducing or against the severe disease and the death and the hospitalizations. Where there is a slight difference is that, like in all the other variants, these vaccines were also found to be effective in preventing the spread of the disease. But in case of Delta variant, that's where the vaccine effectiveness is not as effective in preventing the spread of the disease. The breakthrough infections are rare in all of the first 3 variants, alpha, beta, and gamma, but there are small proportions of breakthrough infections that are being seen in the Delta variant. And why is that? We will go into a little bit more detail later on. When it comes to the treatment, the monoclonal antibody treatments were effective against the alpha variant. Certain monoclonal antibodies were not effective against the rest of the 3 variants. And again, that is because of a specific mutations that have occurred in these variants, and Delta variant is not different from gamma or beta in those sense when it comes to the treatment options which are available. Next. Now, what has made Delta variant the most commonly circulated or infecting the most population right now? You see various different news headlines coming about, and which we did not see when it was the alpha, beta, or the gamma variants in the United States specifically. Right now, we are dealing with another peak in various different regions of the United States, and most of these are being called or caused by the Delta variant, and approximately 95% of these infections are Delta variants. Just to go over a little bit more detail as to why there is such huge outcry from the public health officials about the Delta variant and possibly future variants as compared to the previous variants that we had seen. Next. In order to understand why is Delta so different as compared to the other variants, we have to I'll just give you a brief overview as to how the COVID-19 virus actually enters into the human cells. Right now, how the COVID, I mentioned that corona type shape or the crown type shape with the spike proteins which are projecting out. These spike proteins actually get attached to the ACE2 receptors on the human cells, and which is actually the changes which are brought about at that site result in the entry of the virus into the human cells. Now, these ACE2 receptors are present in the mucosal cells in our nose. They are present in our gastrointestinal systems, and they're also present in other systems in the body. And that is why you have seen this plethora of symptoms that you see with the COVID-19 infections. We started off with this infection being that of infecting only the lungs, but eventually we found out that it was infected. It was also causing other systemic organs, various different symptomatologies and diseases and outcomes as a result of the COVID-19 infections. So these ACE2 inhibitors and spike proteins are the ones where most of the changes when it comes to these variants are occurring. Not the ACE2 inhibitors, but the spike proteins in the virus, which are affecting these ACE2 inhibitors in a way which is causing increased transmissibility. Next. So I have given you the names of the mutations, which I initially thought that I would keep out, but just to give you an idea about, these are the mutations which are specific to the Delta virus. And as you can see on the top, the Delta P1.617.2 is the official genetic lineage name of the Delta virus. There are certain mutations which are common in both alpha, beta, gamma, and delta, which I have not mentioned here. So eventually when the virus mutated to the Delta virus, there were some specific changes that occurred within those spike proteins, which are attaching to those ACE2 inhibitors, as a result of which it made it more transmissible. Now, what are these changes? Number one is the mutation, which is D614G. What is that actually causing? Is that it is causing the increased density of the spike protein on the surface of the viral particles, making it easier to enter the cell. So there are more of those spike proteins on the surface, thereby providing more areas to get attached to the ACE2 inhibitors, and as a result of which increasing the entry of these cells into the human cells. Then the next one is basically there is a specific mutation which is causing high viral loads in the patients. Again, this mutation is occurring within the spike protein of the virus, which is causing, as you are seeing, and I will go into a little bit more detail, is that the patients who are infected with Delta variant are spreading it to more people because there is more higher viral load in the patients who are suffering from the Delta variant COVID-19 infection. The L452R mutation basically affects the receptor binding domains and acts to prevent the antibodies from neutralizing the virus. As I mentioned in the treatment options as to like what has changed from the original COVID-19 virus is that there have been some changes on the receptor binding proteins, as a result of which some of the monoclonal antibodies are actually not working on these later variants of the COVID-19. Another mutation which has occurred which makes the Delta variant to be highly infective is it is located on the receptor binding domain in the area of the COVID genome that helps the virus fuse with the human cells. So there is this receptor binding entry into the cells, and then there is this fusion of the cells which helps the cell enter into the human cells or inject its genetic material into the cells. And this mutation is actually helping with that piece of entry of the virus. So everything that is happening is, one, making the virus easier to enter into the human body. And number two, it is causing the changes within the virus, which makes it, in layman's term, less identifiable by those antibodies to act against the virus and prevent the symptoms of the COVID-19 or the infection of the COVID-19 from happening into the humans. The last mutation is that the N-terminal domain. Again, it is at the domain which serve as the super sites for the antibodies, and again, it reduces the effectiveness of the antibodies, especially the vaccine antibodies which are presented. And that is why we are seeing those breakthrough cases more in the Delta virus as compared to the other variants. Next. Now, what has that resulted with all these mutations? What we're seeing with the Delta variant is that as of July, this variant was detected in 130 countries that we know of. And this is as of July, so this number has definitely increased after that. The other thing which we are seeing with the Delta variant is the incubation period of 4 days versus the 6 days that was seen in the previous variants, which means that the infected people start spreading this disease a lot quicker as compared to the previous versions of the variants of the virus. Then again, as I mentioned, that it is because of the increased viral load and increased transmissibility, the Delta variant, a person infected with the Delta variant is actually infecting 6 people as compared to the 2 which was previously with the other variants. And it isn't, like I mentioned during my initial side-by-side comparison, it is not like that this virus is more lethal than the other variants which are out there. It's just that because of all these characteristics combined of increased transmissibility, high viral load, ability to infect people who are even vaccinated, that this virus is causing a lot more disease and a lot more hospitalization and deaths as compared to the previous variants. Next. This is just a visual from CDC to give you an idea about how much more this virus is able to spread as compared to the other variants. Next. Now, as a result of this increased transmissibility, I mentioned that before, but this gives you, like, throughout the United States and all the states, including the District of Columbia, around 95% or more of the infections that we are currently seeing are due to the Delta variant. So if you get COVID-19 right now, if you're unfortunate enough to get that, it is most probably, but like more than 95% chances that it is a Delta variant infection, because that is the variant that is out in circulation right now. Next. Now, this gives you another view of how the Delta variant has taken over since June of this year in terms of the variant that is out there in circulation. Again, it is like around 98% to 100% of the infections that we are currently seeing are the result of the Delta variant, which you can see here is identified by its the scientific name as well, the genetic lineage. Next. Now, I personally wanted to know, like, if the Delta variant was slightly different in terms of symptomatology as compared to the other variants. But But the thing is that although we cannot say that there are specific symptoms that help you identify, oh, this is Delta variant and this is not, but there are some changes or some trends which are being observed right now in the patients infected with Delta variants. In addition to all the symptoms that you are already aware of, which occur in the COVID-19 infections, fever and cough are the ones which are usually present in almost all of the type of the variant infections. But what is being seen with the Delta variant infection, and there are more studies right now being done, but the limited data that is present shows that the loss of smell and taste, which was like the hallmark of the COVID-19 infection in the beginning phases in early 2020, and then up until more recently, as the main symptom of COVID-19 is less commonly present in patients right now who are being infected with Delta variant. It's not that it's completely absent, but it might or might not be present in patients with Delta variant. Again, the GID symptoms that were again associated with the initial early COVID-19 infections like nausea, vomiting, diarrhea, they are less commonly being seen with the Delta variant infections. The symptoms which are more commonly seen with this Delta variant infections are sore throat, headache, runny nose, and sinus congestion. So the symptoms usually mimic the upper respiratory tract infections, and even sneezing. Increased sneezing is also a symptom which is being observed in some of the patients with the Delta variant. And for vaccinated individuals specifically, because they are not going to get a severe disease, these symptoms easily resemble that of a common cold or allergies, and patients may even not know that they're infected with the Delta variant and spread it to other individuals. I recently got infected with COVID-19 despite being vaccinated, and I can say that sore throat, headache, and runny nose and sinus congestion were my symptoms only. So it is something that is seen in, again, these are not like, you cannot say that if I'm not getting loss of smell and taste, it is definitely Delta. It is Delta probably because that is the variant out there, but symptoms cannot be just used to identify the type of the variant that is infecting you. Next. Now the standard of care. Now, I will go over some of the things, some of the information over here regarding the drugs which are approved by FDA for the treatment of COVID-19. That has not changed a lot with the various different variants that are out there. Like I said, most of the authorizations which are out there when it comes to completely authorized drugs for the use of therapeutic use for the patients of COVID-19, as well as emergency use authorizations, have modified a little bit, but they have not really changed a lot with the various different variants. So the diagnostics piece of it and the treatment piece of the COVID-19 has not, we have learned a lot more than we did back in 2019 and 2020, but it is, the variants have not caused a lot of change in those protocols. So the only drug that is approved by FDA, like fully approved by FDA for the treatment of COVID-19 is remdesivir. This is the only drug. There are specific requirements, however, for the use of this drug as well. And in our resources, we have provided the NIH, and even on this slide, the treatment guidelines is, if you click on that, you can go and see where each of these drugs is recommended by the panel that was established by the NIH. There are certain drugs which have been approved by FDA under the emergency use authorizations to allow the healthcare providers to use the products that are not yet completely approved or that they're approved for other purposes and not necessarily as a treatment protocol for COVID-19. Like I said, like there's only one drug which is completely approved, but there are emergency use authorizations for others. Again, as I mentioned, the treatment guideline provides the exact treatment, like there are specific requirements if the patient requires oxygen, if the patient requires forced oxygen, and then there are various different things if the patient is discharged from the hospital and if the patient is not hospitalized, on how these treatment regimens are going to take place. But I will just give you the overview of the various different drugs which are out there. Next. Now, these are the drugs, and a lot of these are actually, they include the antibodies. They also include some of the drugs used for anesthesia purposes when the patient is on the vent. And like I said, that mentioned in the previous slide, there are certain emergency use authorizations which are provided for the drugs, which were already in use for other purposes, but specifically for this treatment for COVID-19. Again, in the treatment guides that you can access from the website, there are specific requirements for all of these drugs on when and how they can be used and what dosage is usually recommended. Other than that, again, there are certain antibodies which are not effective against the Delta variant viruses that we're seeing right now, but all of these have had the emergency use authorizations. Just to give you a brief overview of the management of the non-hospitalized patients with acute COVID-19, one of them is providing the supportive care. Then there is also taking steps to reduce the risk of COVID-19 transmission that Taylor will go into detail on how those mitigation efforts need to be brought about. And then the last one is the advice to contact the healthcare providers. There are a lot of patients out there who do not have the need to contact their healthcare providers just because they don't have the symptoms that are severe enough to do so. But getting in touch with your health department at least is recommended. Next. And then the therapeutic treatment, I have only included the information about the ones which are not requiring supplemental oxygen, as like if the patients require supplemental oxygen by various different means, the therapeutic regimens, they keep changing, like they change, and there are specific requirements and which are more pertaining to the clinical individuals and not necessarily the people on this call. So I did not include that, but a few of those is like, again, monoclonal antibody products are recommended. Then there is a recommendation against the use of dexamethasone and other systemic glucocorticoids in patients who are not requiring supplemental oxygen. However, this is kind of like, this is a recommendation, but there are providers who are not necessarily following these. And there are some studies out there to see the efficacy of these, even in patients not requiring supplemental oxygen. And then there is also the recommendation against the use of some of the drugs which are actually authorized through the emergency use authorization. I think next I hand it over to Taylor, who is going to go into a little bit more detail about the mitigation strategies and some of the other things.
Perfect. Thank you, Amna. While we have a quick pause here, do you mind answering the question we have in the chat? How will people know whether they are infected with Delta or not? You are told positive or negative when you get a test.
So you will not get notified if you are infected with the Delta variant, if you get a positive or a negative test. That is not shown on the test that is available. Seeing the data that is out there, like I mentioned, 95% of those infections are Delta. So probably if you get infected right now, it's going to be the Delta variant, but you're not going to get that information from your test. Taylor, do you want to add on to that?
Yeah, I was going to add, I believe it's in my understanding that different states have different types of sampling strategies that they go and send in these tests for sequencing, so they understand what is the distribution of variants in their community. So that information doesn't go directly to the patient, i.e. you, in that particular incidence. But at this point, I think Amna showed quite well, and we'll talk more about it in this upcoming section of the presentation, at about 95 to 98% Delta prevalence in various communities across the US, it's very likely that is the variant of infection. Perfect. Again, feel free to add any additional questions in the chat. We'll have time at the end as well. So again, thank you very much, Amna. I'm going to hand it over and go into more of these mitigation strategies and go through a bit of a rapid fire through a multitude of various resources that can aid your community's response. As we're aware, here at the UMTRC calls that we have a variety of different healthcare providers and public health providers all on the continuum. So because there's just a rapid amount of information, to make sure we highlight some of these dashboards and resources and the like. So to really go on more with the mitigation conversation that we're having here, it's really the core concepts coming down to the masking, surveillance and isolation, as well as vaccination. I have linked here the approved vaccines in the US, as well as the information that is relevant for those. But I love this graphic right here. I think throughout this whole pandemic, which, I mean, it's been more than 18 months now, masking has been one of those key core concepts in order to prevent community spread. And as we know from a variety of studies in material science and epidemiology, some of which we'll go over here in a moment, there's a variety of effectiveness with mask materials, not to mention the way in which you wear them, techniques in which the mask is worn. And so just a great diagram showing the potential spread as well. And a lot of the guidance had recently changed, I suppose, in the last 2 months or so, back with, I think the news cycle went rather quick on this, but there was some evidence that came out from the CDC's Morbidity and Mortality Weekly Report from a COVID infection, community COVID infection or outbreak, I should say, that came from a 4th of July celebration in Massachusetts. And this was one of the main pieces of evidence that suggested that that not only unvaccinated but vaccinated individuals do shed virus, and that's what alluded to the universal masking guidance update from the CDC. So next, I wanted to play just a few seconds of this video here. I'm always particularly interested in material science as it relates to masking and mitigation techniques. So let's see if this one will play. I'm going to mute the video so you don't have to hear the stock audio of a cough. But this video shows simulated through fog and also some lasers the distribution of a cough when it's unmitigated without a mask, as well as various masks that are being utilized. And we'll go through some more literature on that in a moment. But I think a picture is worth 1,000 words, and even more so with a video. So here's demonstrated a respirator with a valve, obviously does not prevent spread with the community. And then getting more into the fit of the mask with loose cloth and how, while it can reduce some aspects of spread, it can still emit particles at the top and bottom. So that's why it's so important to have that excellent fit. And I failed to mention that this is from UW-Madison as well. I'll give this about a few more moments. All right, perfect. So we'll head over to the next slide here. And so in that similar vein, there is a great amount of work that was provided by the Environmental Protection Agency, which did a review on the left being the types of consumer grade masks and their filtration efficiency. So you'll see that in regards to different amounts of layering and material. And then particularly on the right, you will see as well guidance on different types of techniques of wearing the masks in order to improve that efficiency as well. And the links down below here is the source for these figures, but as well listed here as well for many of our healthcare workers is the FDA guidance for NIOSH N95 approved masks. So if you want to search for distinct manufacturers so that you know you're getting an appropriate mask, appropriate N95 mask, you can get that from a reliable manufacturer. And this is that portion right there. The other type of innovation that we've had throughout the past few months comes down to at-home testing. This has been particularly vital in many communities as it relates to school safety, school quarantining, and isolation. But there's a few vendors out there, but I wanted to highlight probably the best publicly known, the Abbott Bionex Now testing kits. And there's some good evidence that was found of using this type of platform in a community-based setting in Pima County, Arizona, back in November. Really demonstrating the sensitivity and the specificity for these tests for both symptomatic and asymptomatic coronavirus. So if you've never used one of these particular platforms before, this is just the vendor stock imagery that they have, but it is a nasal swab that comes with a card that you see listed here. And prior to the swabbing, there's 6 drops of the PCR amplification solution. And then the nasal swab sample is placed into the PCR card and it incubates for 15 minutes in order to generate that positive test. And with that, and as we've demonstrated with this from the MMWR and also from the vendor materials, the sensitivity being that 91%, it's a very effective platform for reducing community spread. So again, that is just only one platform. Additionally, another aspect with mitigation is, of course, vaccination. There's been a variety of interesting studies and real-world evidence regarding vaccination status, spread, and outcomes, of course, as well as reinfection with those who have or had a previous infection. So those who have natural immunity or those vaccinated. And particularly an interesting study comes from the MMWR with this case control study, this retrospective case control study that most simply put compares vaccinated status and whether individuals in Kentucky communities were reinfected. And what was found with that is that of those who had a prior infection but were not fully immunized, they had an odds ratio of 2.34 of getting infected. So 2.34 times more, I want to say more likely, I'll say more likely for lack of a better term presently of getting infected again. We did see some interesting results for partially vaccinated, so maybe one step out of a 2-step vaccination platform. However, that 95 confidence interval goes through 1, so that is not significant, but really quite a fascinating study that highlights the importance of being fully vaccinated as a mitigation technique. And so that's really what brings us to this next section is that, again, outbreak dynamics are rather complicated. I think any epidemiologist would agree with that. But one of the big drivers that we've been seeing in the literature is that with this highly infectious Delta variant, that vaccination status is a huge driver of outbreaks. And so again, just another repeat of what Amna had mentioned in her section. Really designating that the original strain really affects one person affects 2.5 people versus the alpha variant being 4 people and delta variant being 6 people. And that's what you'll see with that, what a lot of epidemiologists will refer to as that R naught value, that R0. That's really what that means. So 1 would be a 1-to-1 infection. So one person sick infects another person. And I'm sure this is a graph that we're all quite familiar with this day and age. This is the national daily case curve, really going through that 5th wave here. And really just as we're through our Delta surge over this summer and entering now into the fall, we see that community transmission is high as well as our deaths rising. Fortunately, our cases are being a bit stagnant, but still rather high there. So again, this is taken from the CDC's national dashboard. And really to segue and dive a bit more into this community transmission aspect here, We have listed, unfortunately, a rather red map that's designating the amount of community transmission in each U.S. county. And so we have about 94, well, actually almost 95% of counties being at high transmission values. And how that's defined, or how the CDC is defining that, really comes down to new cases per 100,000 within the last 7 days, as well as percentages of nucleic acid tests as well. And so, as we can see with this rise of the Delta variant being, again, anywhere from 90 to 95 to 98% in our communities, and that increased transmission, it's definitely playing a large role in the unique characteristics of our outbreaks presently. And so I'm aware of the audience on this call for the Upper Midwest Telehealth Resource Center. So I really wanted to take, I guess, a more of a tighter focus compared to what Amna had already introduced, and really go into the Health and Human Services Region 5, which covers much of our geographic area. And as we can see, going back from really the 12th of June, all the way up into about a week ago, we can see that indicated with this orange color that the proportion of cases are very much so Delta. So it's rapidly overtaken the other coronavirus variants. And again, routing back to vaccination status as being one of these mitigation efforts, there's a wide variety of a proportion of those who are fully vaccinated. And so we have Indiana here, but this is just a sampling of some of the U.S. states that goes anywhere between 40% of the state's population up above 60%. So again, there's a lot of variability, and that can really really drive the unique characteristics of this fifth wave. And additionally, there's been amongst Health and Human Services and other governmental and non-governmental actors, a large focus, particularly on vaccine equity. Because if we go back to our original dashboard, I think we had a rather steep amount, or a rather high amount of those Americans who have one vaccine shot. But again, it matters of where the vaccinations are occurring within the community. So more simply put, uneven distribution of vaccine status can result in hyper-localized outbreaks. And so I don't like to anthropomorphize the virus, but the virus will likely target these communities with low vaccination status due to its highly infective nature. And so I wanted to introduce a few different types of dashboards that are available that can help guide your response in your community. And so this particular one comes again from CDC. It is the percent population fully vaccinated as by social vulnerability index. And this index, I'm not going to go through all the methodology here today because, again, we're running low on time, but the social vulnerability index will rank different counties and communities in order of how vulnerable they are based off of various social and behavioral conditions, such as housing availability and food and the like. And so you can use this to best rank and see what communities may be particularly vulnerable to the unique aspects of this coronavirus. And so what we have here in this chloropath map is we have the social vulnerability index on this x-axis here, and we have on the y-axis, we have a percent population unvaccinated. So I encourage you, and again, the link will be sent out on our slides here, to really hone in on your community to see how the various estimates of community vulnerability in your communities. As well, another dashboard that we have here. This slide froze. One moment, please. Oh, pardon me, let me stop sharing for one moment. PowerPoint crashed. But what I'll show you next, just for time's sake, is that we have an additional dashboard that is focused by percent population that is vaccinated as it relates to rural and urban status. So let's get back into it. There we go. Apologize for the technical difficulties. So again, similar map here. It's a percent population that's fully vaccinated by metro and non-metro status. It can be used as well to highlight the unique aspects of your community and vulnerability. And again, here IRHA, we serve Indiana, and so I wanted to bring it home as far as using Indiana as an example for to demonstrate of how vaccine distribution is not quite even. And so in the blue, we have high amounts of the percent of the population that is fully vaccinated. And in the red, we have populations that are lowly vaccinated. So obviously that northeastern portion of the state, as well as other pockets, have particularly low amounts of vaccination status. And that is, again, ideal or less than ideal for mitigation strategies for a Delta outbreak. Again, various states as well have other aspects that you can quantify the populations that are vaccinated. So here again in Indiana, the blue being the percentage of those who are fully vaccinated according to age strata. And then as well as going through the variety of comorbidities and chronic conditions that particularly indicate poor outcomes in COVID patients. It's a great tool as well. And the types of conditions that are outlined here with this chloropleth map come down to chronic kidney disease, COPD, heart disease, diabetes, and obesity. So it can help target and select communities for various mitigation planning. So again, I know we're running out of time here, so I want to finish this off with a quick highlight of future threats. And as Amna had mentioned previously at the beginning of our presentation here today, is that there's obviously the difference between the variants of concern and variants of interest. And so just a reminder of variants of interest. These are those that have genetic changes that are predicted or known to affect the virus characteristics such as transmissibility, disease severity, immune escape, diagnostic and therapeutic escape, and identified to cause significant community translation or multiple COVID-19 clusters in multiple countries with increasing relative prevalence alongside increasing number of cases over time. So again, this is straight from the World Health Organization, their working definition. And the particular one we want to make sure that is on your all's radar among many, but is particularly MEMU. MEMU is one that has been highlighted. Well, it was actually classified the 30th of August as a variant of interest, and it's being heavily watched due to its concern of vaccine resistance. And so again, this is taken from the World Health Organization's weekly epidemiology report that's also linked down at the bottom of this slide here. But particularly that these mutations that the MEMU variant has indicate potential properties of immune escape. And so there needs to be a lot more study to confirm this, but that is the current prediction, is that there could be a reduction in the neutralization capacity of convalescent and vaccine sera, similar to that as the beta variant that we have had previously. Additionally, at the time of the poll, the 29th of August, this MEMU variant had been present in 39 countries, but it's much higher now. I think it stands maybe a week or two ago at 51, but it's likely much higher than that previous 39. And this variant came, or at least was first identified in Colombia and Ecuador. And so I'm going to, again, I know we have about 6 minutes to the hour here. I wanted to highlight just a few resources on this slide that may be helpful for you and your practice. We have those standard of care resources that Juan Amna had mentioned from the NIH. This is additional a review from Cochrane Reviews right here. And then there's additional information from the Delta variant from the CDC, as well as various variant surveillance tools as well, next strain, as Amna had mentioned as well, and various community outreach and response toolkits that can help your practice, not to mention health professional vaccine education and patient education materials as well, as mentioned as this mRNA patient education poster that's available, not to mention many others. And then lastly, there's a lot of misinformation online. So there's a great amount of resources in order to best evaluate and critically analyze vaccine information online. And then finally, this is that next strain phylogeny graph here as well, if you have any interest in tracking variants. So I am going to hand it over for a Q&A session now. And I appreciate it, and Anna appreciates it, and thank you for dealing with that technical issue as well. So let's see what we have in the chat.
Thank you so much, Taylor and Amna as well. I'm blown away by all this information, so thank you very much. I wanted to go back a couple questions, and as I'm talking, I'm going to ask Carolyn Miller to go ahead and put the survey in the chat. So if you'll take advantage of that, if you want to chat other questions into the chat box, please go ahead and do so. But I wanted to go back to, we were talking about how do I know if I've got the variant or something else? And I was curious, and I think Amna, you might be the person to answer this better. What is different in this fourth wave that we're in now versus the first wave about how patients that are sick enough to go to the hospital get treated?
As far as the treatment is concerned, when it comes to like the protocol of the treatment, it has not really changed that much from the information that we had from the prior variants. So a lot of that is still working. Like I mentioned, that there are certain monoclonal antibodies which are not effective, but that has been the case start from the beta variant onward. So our physicians or the clinicians are already aware of what is working for the patients and what is not. The thing I think which we are seeing is that the patients who are actually ending up requiring that therapeutic treatment in the hospitals are mostly the ones who are unvaccinated. So that is the change. And the other change with this variant specifically is that the demographic has changed. Initially, in the first wave, we saw there was the older or the elderly people who were getting infected and dying of the disease. But now the hospitalizations have expanded to peds. And unfortunately, from the ages 6 to 12, we still don't have any vaccinations. So kids are getting infected more with this virus with symptomatic infections, like kids were still getting infected and not really heavily symptomatic with the previous variants. But right now, the kids are actually getting infected with symptoms, hospitalizations, severe diseases, and in some cases, unfortunately, deaths as well. So there are certain emergency use authorizations which have age limitations for the drugs. So that's where the difference is right now, because there are certain drugs which are not being used in ages 12 and under, which can be used at ages 16 and over. And so those are the only changes that I would say that we are seeing right now.
Thank you very much. Other questions from our listeners, from our audience today? And I know, Amna, you and I both have kids that are under that current vaccination age, and I've been watching that very closely. I did hear that the CDC plans to make a determination on that soon. Have you had any other information, either of you?
I think the latest I heard was in October. But Taylor, correct me if I'm wrong, but they're working on it and we might have something, but there's no definite deadline. It has been pushed previously. So as of now, I'm not really sure.
The only thing go for it.
I was going to say, I'm just waiting for it.
The only thing I would add to that is I think I saw the report this weekend that Pfizer has published their study for 5 and up. For that application, but I'm uncertain of when that approval would come.
All right. Well, thank you very much. I'm not seeing anybody else populating questions in the chat. I'm going to give one last call for questions. And again, thank you both for such excellent information. I look forward to getting the copy of the slides as well.
Will do. And if there's any other questions that happen after the fact, please feel free to contact us, as well as if you dive through any of those resources that are affixed to these slides and want further explanation, please feel free.
Yeah, also, I'll go ahead and put in just our blanket email for the UMTRC is info@umtrc.org. If you have additional questions that come to you later, please feel free to send that in to myself or to Taylor or Amna or Carolyn. We've talked about doing future webinars on this particular topic and welcome your request for topics. So thank you all and have a great day.
Thank you.